Well, the hip joint is, of course, right up and through here, and it's a ball and socket joint. So my hand would be like your socket, and my other hand is the ball. So it's a spherical joint. It's a round joint. Your body weight goes through it depending on what you're doing, but roughly 2 to 3 times your body weight goes across your hip joint, because when you're walking or running, you're putting all your weight on one side for a period of time, and so there's extra loading on that joint. The decision to operate or to offer surgery. It's what we call elective. In other words, the patient is the one who has to decide, but they need to make an informed decision based on what's involved with the surgery, what the risks are, and long-term risks and benefits. People think of the benefits of surgery, not necessarily the risks. And most people do very well, but there can be some considerable risk with it as well. So it's a combination of all those factors. But the patient has to be involved in the decision. It's what's called shared decision-making, because as a surgeon, you're not feeling their pain. You're not feeling how much that loss of function is affecting their lives. And some people it could be a small thing, others it can be a really big deal. So that's why as a surgeon you can get a feel for that, but that's why the patient has to ultimately decide. It's a very common procedure now. Several 100,000 are done every year in this country, and the number's growing. But as I said before, you've got your socket and the ball, and basically a total joint, which is what we're talking about, is replacing both sides of the joint. Why is that important? Well, because there's cartilage that lines the socket, cartilage that lines the ball, and with bad arthritis, that cartilage is gone on both sides of the joint, so you need to replace them both. It's actually not a new approach. Believe it or not, I actually trained on that approach when I was at Yale back in the 70s. But back then we were cementing the implants, and there was a little more, the implants were smaller, and so it was a little easier to get at the femur. When you go into the front, your hip joint is actually closer to the front, and it's very easy to get at the socket, but it's very difficult to get at the femur. So I had done, thousands of implants posterior with really good results, but then a table was developed, an orthopedic table that actually has a hook you place sterilely at the time of surgery, so that after you get the femur, what we call mobilized, or get it freed up enough, you put this hook to hold it there, so then you can prepare the femur. As I gradually changed over, I started seeing how the patients were doing, and particularly patients who had one I had done, say, the traditional way and one the newer way, and they were liking the newer way. And I thought that was just a short-term benefit, but it's interesting now that I've been doing it now probably close to 10 years again. Patients still remember getting going quicker, and the experience, they, in general, have tended to like this anterior approach.
University of Iowa Healthcare. Changing medicine, changing lives.